So this is a review of the meeting that was held on January 30th, 2019 in the Respiratory Care Department about RT safety. So we always like to start a meeting with reflection. So today is all we have. We cannot live in the future and we cannot live in the past. So being mindful is very important, especially in the job that we do. So here's a little thought on that. Life is lived one day at a time. Learning to live mindfully means taking time to pay attention, to pause, and listen to what is happening within us and around us. Mindfulness allows us to create a space where we can stay focused on the present moment, nourish our spirit, and receive the gifts awaiting for us. So the ask here is to think of a time when you've been mindful at work. In today's presentation, we'll discuss the role of the RT in the National Patient Safety Goals, personal protective equipment and safety, patient equipment and safety, and medication safety. As in any case, safety starts with the individual, and it's that willingness to participate in safe environments and safe systems that allows us to provide safe care for our patients. So again, safety is a measured decision made by you. National Patient Safety Goals of 2019. This is established by the Joint Commission are to identify patients correctly, improve staff communication, prevent infection, use alarms safely, and use medicine safely. As we have experienced since the inception of our intensified tube patient identifier system at St. Alphonsus, this occurred in June, July of 2019, or 2018, excuse me. We're to use at least two ways to identify the patient, and it's the patient's name and the date of birth. This is also important when we are labeling specimens or arterial blood gases. And with that too, there's an additional caveat that now when we're labeling, we need to put the first initial and our complete last name on those. Date, time, sample being obtained, and other pertinent sample information, for example, FiO2 if arterial blood gases, source of sample if we're dealing with sputums. If we're dealing with an unresponsive patient, we definitely have to do an out loud verbal readback off of the name band as to the patient's name and date of birth. So MPSG 020301 states that there needs to be improved staff communication. Three things here in the RT department at St. Alphonsus. First being that we do chart-based reporting, no table report. This allows us to open up orders and determine that the order is correct, determine vent settings are correct, determine BiPAP settings are correct, that we use the situation background assessment recommendation format for reporting information so that information pertinent to the patient's care and safety doesn't fall through the cracks. And that when we're dealing with critical values based off of blood gases, that we make sure that we use our critical value reporting sheet that's within the arterial blood gas. We do a great job with our critical value reporting with our blood gases and our dates. Remember that we have our critical results test page here, and this makes sure that we are notifying the appropriate provider, whether it be an NP, PA, or physician, and then down here are critical results details and then actions taken for those critical results. So we're doing a good job with this, so keep up the good work. In MPSG 030401, again, using medication safely, that readback patient name and birthday identifier comes into play again. Home medications do absolutely need a physician's order. The patient just cannot use home medications willy-nilly and none. And that when we're talking about medication security, medications have to be locked up. Especially in the peds floor, we need to make sure we're throwing away the plastic pieces so there's not a choking hazard at bedside or near the bed. and that their medications kept separately in a lockbox behind the nurse's station in the Pyxis room. We cannot, for pediatric patients, keep medications in the room. I know we use a split room on 5 Central, so if we have an adult patient in a peds room, well, it's an adult patient in a peds room, so you can have it in the locked box. However, if it's a pediatric patient, it needs to be kept separate from the patient. Most of our peds wind up on 5 Central, so this isn't an issue in other service areas. So preventative infection, something we do very well in the RT department, whether it be our art line with our chlorhexidine patch, which when we do our checks or our audits, we are completely compliant with that, to our chlorhexidine scrub twice a day that prevents and keeps our VAC rates down, to just general basic hand wash. Real big emphasis on hand wash as always, but Joint Commission's looking at this particularly closely. In other organizations have written type 1 violations for folks that weren't properly following hand washing procedures. And this includes also observing hand washing procedures if we're dealing with patients who have C. diff, that it's soap and water and not alcohol scrub for cleansing our hands before and after care of those patients. So we do a fantastic job with hand washing. The hospital is now taking an approach of having hand washing observers out on the floors that will track departments and make sure they're compliant with the hand washing practices that are germane to St. Alphonsus Regional Medical Center here in Boise. So be aware there are going to be lots of eyes watching us, making sure that we're following proper hand washing technique. Using alarms safely, 3 bigs that we got to be definitely aware of are on our AVIAs, our V60s, and our MPAP units. It goes into this clinically appropriate settings for alarm signals. When alarm signals can be disabled, got to be very careful with that. When alarm parameters can be changed. So we can change alarm parameters. We definitely have that authority to do that within our clinical assessment, what's going on with the patient. So who in the organization has authority to set alarm parameters? We do. Who has the ability to change them? We do, based on our patient condition. And also the authority to set alarm parameters to off. No one has really that authority. We will turn alarm parameters off if we're working with a patient who is transitioning to comfort care. And that's more of a convenience for the family to allow a peaceful transition to another realm. And so that is about the only case that I can think of where we're allowed to turn them off. Other than that, we have to make sure our alarms are set appropriate based on the patient condition that's presenting itself. Monitoring and responding to alarm signals, just make sure that we're doing our Q4 alarm checks, especially at times where we're reducing the number of ventilator checks based on patient census. We need to absolutely make sure if we're doing Q shift vent checks that those alarm parameters are set correctly, and that if the dynamic changes for respiratory rate or tidal volume and there are alarm values that need to change as well based on patient condition or mode or volume or respiratory rate changes, that they coincide with those changes that have been made with the patient. Now we're going to talk about personal protective equipment and safety. If you are a PAPR user, there's good news. We're switching PAPRs, so the AirMate is going to be phased out. When that is implemented, I don't know yet. I know it's coming. We're to use the rest of the AirMate supplies until then, and then they're going to introduce the new PAPR device. There will be subsequent training and checkoff to follow, but if you do in the meantime need a PAPR device, it will be the AirMate, and all you need to do is call extension 7972. That's the equipment depot's number, and they'll get a PAPR unit up to you. We do not have them in the back room any longer. Tracheostomy tube changes, making sure that we have our mask with face shield and our gown and our gloves on when we do these changes is important to your safety. And so some other things we're going to do is this will be a competency for fiscal 2019 coming up. We'll be doing tracheostomy changes and walking through the procedure to make sure everybody understands how to perform these per procedure. When it comes to bronchoscopies, we're doing a great job making sure that we're putting on masks with shields and gowns. That everybody in the room that's in association with that procedure has a gown and a mask with shields. So good job, everybody, with that. A couple of other points here when we're working with MRSA in the sputum. We need to make sure that we are wearing a mask with shield. That is droplet precaution. We don't want to get blasted if somebody were coughing in our face. And then with our RSV patients, there are a lot of places that just but use this as a contact isolation. It technically is droplet. I know that we are trained to have the gown, the mask, and the gloves to make sure that we aren't getting contaminated ourselves and we won't pass that contamination on to other patients. So, to further personal protective equipment and safety, we have airborne droplet and contact. Contact is our base, so gloves and gown, our MRSAs, our C. diffs. And just remember, as a side note, with that C. diff patient, that isolation, we need to make sure that we're not using alcohol, that we're using bleach to clean equipment, and that we're using hot water and soap to clean our hands. In the droplet orientation, we need to make sure that we're wearing not only gloves and a gown, but also a mask. And in airborne, we're either using our N95 filter mask or a PAPR. Now, what's interesting about airborne is there has been a measles outbreak. And so measles is considered airborne contamination. There's going to be literature rolling out, probably posted on the safety board and on emails and on screenshots about how measles is transmitted. Big outbreak in Washington, big outbreak in New York. So make sure if we're suspecting measles, and measles is the kid will have a fever, cough, they'll have inflamed mucous membranes. Rash is kind of the big identifying sign. Those kids are particularly contagious 4 days before the rash presents and 4 days afterwards. So we need to make sure that we're thinking measles if we see something that looks like this. I don't know if it's going to really affect our pediatric population here in southwestern Idaho. We have pretty good immunization rates, and so does eastern Idaho. But that doesn't mean we might not have a child that's traveling that winds up in our facility. So think airborne. When you're working with measles patients, also another caveat is we cannot have pregnant female care providers taking care of patients who have measles. Personal protective equipment and safety. When working with the ultrasound, we provide a nice halo of safety for our patients because we're determining that arteries are the appropriate size. We have a great process flow that we do with that, so good job everyone for marking those and writing those down in the progress notes. Our procedure for performing an arterial line insertion is bar none. We sterile gloves, sterile field, 3-minute dwell time with the chlorhexidine. Looking great. We're doing a fantastic job with this. Actually non-existent infection to line issues going on with our arterial line patients. Making sure that we're properly securing that is going to lead to success of keeping that line in, and often the cause of decannulization is drift. People aren't paying attention to the line, or maybe it wasn't secured properly, or the site was cleaned and it was reassembled and it probably wasn't done in the correct manner. So these are things we need to be checking when we're doing our vent checks as well, to make sure that that is correctly secured and that it doesn't lead to a decannulization for the patient. Injury on the job. Nobody likes getting injured on the job. Two big areas we got to constantly worry about are needle sticks and blood exposure because of our position and what we do here in the facility. A code safety has to be enacted, and that's started by your immediate shift supervisor. They call the MAC, and the process begins. Now, the code safety isn't to provide a source of embarrassment for the person being injured. The code safety is to provide a layer and guarantees that that person's going to move through the system in an effective manner to get the proper care and subsequent paperwork filled out so that we can get that individual whole again and get them back to work. So the way code safety works, again, you need to call your supervisor if you're injured, and they will enact the code safety. Of course, there's going to be paperwork. The colleague incident report's going to need to be filled out. A regular voice is going to need to be filled out, and those are submitted. So the code safety team's job is to help with all of this. So it isn't like somebody's out on an island anymore. The idea is it's a team approach. We're helping people who have been injured. If you want to read through this is exactly how the code safety is supposed to work. If you're a supervisor watching this, make sure you read through this and understand. If you have any questions, you can always ask me. The dog biting the guy is in reference to the dog that bit Dan. I love that. I'm sorry, Dan. But anyway, Dan was listening to a patient with his stethoscope, and there was apparently a hidden dog under the sheets that bit him. But according to Dan, it didn't break the skin. He completely shared it with everybody, so we're not violating any HIPAA rights of Dan here. But it probably looks something like this, would I imagine, up here in the right-hand corner. But back on point. So code safety is a process that needs to be enacted every single time there is an injury on the job site. No exceptions. It's a process in which it ensures proper exposure to proper medical need, and then the subsequent paperwork to move a person through the system is filled out correctly. When we're talking facility safety, the big thing here that has been recent is separating oxygen tanks that are empty, partial, full. Really in the RT department, we look at them as empty or full. So if it's at 2,000 PSI or greater, it's full, and that should be kept in the clean storage area. In-use tanks don't count for this. And if it's less than 1,200, it should be in the soil holding room to be picked up later by transported. The pert near oxygen tanks, that's more on the floor. That's what Gordon calls it, is pert near full. And the empty oxygen tank should be kept in the red area over here. So that's pretty self-explanatory. It's been working for a while. So keep up the good work there. Contaminated equipment coming through the hospital can't exist. We need to make sure we're stripping this down the floor as best as we can. We will be written up for a type 1 violation if they see us transporting contaminated equipment through the hospital. So if it is in use going with a patient, that's okay as long as it's covered. But if we're bringing it back for processing, we need to make sure we're stripping this down on the floors, bringing back all the equipment so we're not throwing away heater probes or anything like that. But the disposable equipment needs to be placed in a garbage can on the floor. Further patient equipment safety, we have 3 types of ventilators that have different tubing for pediatric population. Now, all 3 have an adult pediatric circuit, and then we start getting into weight and volume as being kind of the differentiation. So on the Avia, if they're less than 12 kilograms or they have less than 120 mil tidal volume, we need to go to the infant circuit. On the Eagle 2, if they're at 5 kilograms or less than 200 mils, we need to go to that infant circuit. Oh, on the Eagle 2, remember that the default's 21%, so you need to make sure you're watching your FiO2. And on the CrossVent 4, if the patient is less than 100 mils, they need to go to the infant circuit on that. And I have some pictures that you can see here coming up. Also on that CrossVent, you're allowed two levels of oxygen, either 100% or 50%. There is going to be some training and a competency on the CrossVent 4 coming up in fiscal 2019. So coming to a health stream near you will be some review materials, etc., and checkoffs for the CrossVent 4. So this is an example of the CrossVent 4 that we use in patients that have less than 100 mil tidal volume. And here are examples what the packaging looks like for the Eagle over here on the left, for tidal volumes less than 200 or a patient that's less than 5 kilograms. And over here on the right, for a patient has less than 120 mils volume or less than 12 kilograms is what we would use on the Avia if the opportunity presents itself. If equipment is broken, we need to get it fixed and out of the common flow areas, so making sure that we're filling out work orders. We go into the website, we go under work orders, which is under quick links. Under EasyNet, we pick launch for Boise. This screen will open up. We need to fill in what the problem is. Your name is the requester, the department phone number, the tag number if it has one, the cost center is respiratory care, and then the location is the 3rd floor RT soiled holding. Send that off to Randy. We would like it if you can to print the work order, and it will give you a work order. You can write that down and then look up the work order and print the sheet. Or if you, at the minimum, just write it down on a yellow sticky note what the work order number is and put it on the machine, that will help too as well. Further patient equipment and safety issues with Pulmicort, making sure that we're cleaning out mouths and wiping down faces, that we're using a 2 nebulizer system. So if we do have Pulmicort, it's in one neb system, and then if they have subsequent bronchodilators, you're using a different neb throughout the day. High flows, we do a great job of high flow safety. Just again reiterating that a non-rebreather has to be present and set up ready to go in case the high flow were to fail, fall apart, be destroyed by the patient, whatever else might happen. And that we have an oximeter on that patient. We can't have patients on high flow that aren't on oximetry. The pediatric option, we have four high flows that are set up for peds, and they have limited flows on their O2 flow meters that are on the device. And so make sure that if we are putting a pediatric patient on a high flow, that we're using the pediatric option. Please don't tape the high flows together if they're falling apart. Just get a new high flow. All right. Kind of as a Slumgullion quick fire here, we are continuing to do chlorhexidine with our patients. If you're down in ED, you have access to chlorhexidine. You can scrub down there if you have the time. So just try to remember that. Great support within Untitled CO2, both, well, in all areas, whether it be ICU or the emergency room or in CDU. We're doing a great job in keeping patients safe that way. The BioPatch, again, is a classic standard for our art line insertions, so keep up the good work there. Rapid response teams have been shown from an evidence-based standpoint to reduce the number of codes in a hospital, and that is the case here at St. Alphonsus as well. So for December, we responded to 84 rapid responses, and in January so far, we have responded to 79. I believe that's up to 81 now as of this morning. So great work, folks, with that. I know it's not the most convenient time that they have rapid response when rapid response is activated, but just remember it's not a convenient time for the patient either. So keep up the good work that way. In SharePoint, nice thing about SharePoint, the website is it provides a historical perspective to what we have done for safety in the department and keeps it in a chronological order for us to review at any point. So if you're ever away for a while and want to come back or want to review something, you can log into your SharePoint account and look at the information that's there. But we've had 13 safety entries logged into the SharePoint account as of spring 2018. So keep up the good work in reviewing that. When it comes to skin injury, our rates are low. Actually, they're non-existent. For about 2 years now, we have practiced our BiPAP ulcer reduction plan, or BURP, and we use our mask rotation, Metplex, and in the critical care areas, we do Q4 assessment about skin with the RN, and this has resulted in no breakdowns. And so before we enacted this, we had anywhere from 3 to 4 a month occurring, and now we have 0. So that is because of you guys going to the extra effort to make sure that we're switching from over the nose and going to under the nose or full face mask, and using over the nose as our third option with Metplex. And all the cases I reviewed were using the Metplex well, so keep up the good work there. With the Hollister, we're making sure that we're minding the gap, and when we mind the gap, that's loose enough to put at least 1 to 2 fingers underneath the Hollister. The old methodology of right and tight made it to where we had multiple breakdowns and injury to the patient. And now that we've minded the gap here for a little over 2 years, we haven't had the issues we used to have. So documentation, basically, we're tracking this in RT progress notes. We're tracking that we have assessed the Hollister and that we have performed the critical care area, and we can do this on the floors too, but skin assessment, lifting the mask off, cleaning the mask, etc., looking at the skin every 4 hours, and then what type of device we're using. So, push the button, get the bacon. I love that picture. All right, one of my favorite words in the world is MSDS, but it's not a Spanish word. It means Material Safety Data Sheet. And about 2 years ago, the Fed said everybody's got to have the same form. So they switched us to the Safety Data Sheet. And the Safety Data Sheet makes sure that it records the properties of each chemical used in a facility, that we understand that it depicts the physical health and environmental health hazards and protective measures used for that chemical to keep people safe, and then safety precautions. And everybody got to read this their first day that they're working on the job, and then everybody forgets about it. But to find it, you go onto the St. Al's web, you select quick links, you go down to the hot links, and there it is, SDS. You click on that, enter the chemical name. It's going to tell you all this delicious information about the chemical. Now, the time to look this up isn't when you've blasted yourself in the eyes with a chemical, okay? So this is probably what your supervisor's looking up to see how they're going to take care of the situation. I'd say 95% of the chemicals used in the respiratory care department, if we get it into our eyes, are considered an eye flush. So getting to an eye wash station, flushing the eyes is probably paramount if you were injured this way. The other stuff, if it's a respiratory inhalant, you're supposed to separate yourself away from the causative agent. So, with that in mind, safety data sheet, we have had no new chemicals introduced to the department for fiscal 19. If we do coming up, we will definitely have a breakdown, huddle board, review the chemical, the SDS sheet, and then the sign off. So if that does happen, there will be more to come. This is when we're not being mindful. We tend to put the spacer on the expiratory limb rather than on the inspiratory limb. But looking out the window, it's a really nice day out there. So you can see the oxygen tower in the distance. So this is a beautiful RT moment. Oxygen in its natural setting. So safety really does begin with you, but the maintenance of safety comes from good nutrition, relaxation techniques, decompression, getting away, and rest. And it's very important that outside the hospital you maintain these so that not only your family benefits and you benefit, but when you come back to hospital, your patients benefit too, because you're fully rested, you're mindful, and you're observant of the safety systems and how the interplay between you, the patient, and the system work. So that is it. That's the safety talk. We're doing a great job. Keep up the good work with the BiPAP ulcer program, the Hollister, doing an excellent job of art lines, critical care reporting, two patient identifiers, proper labeling of specimens, proper identification of patients when we're doing procedures and meds. Keep up all that good work. Our friends from Joint Commission will be here in about a year. I know it seems so long since they were here, but they're going to come back in 2020 and hang out with us for at least a couple weeks and see that everything's working okay. There will be a build up to this, so don't worry. It's not now, but starting long about November, we'll start doing some review. Thank you for your time. Make sure you fill out your paperwork correctly with your name and date that you took this. Get it into my mailbox, which is mailbox 47, or place it on my desk. Thank you for listening and have a great day.